Well, I'm the incognito person here. I'm Sigrun from the Danish Health Data Authority. Let's see. No. I'll try the next one. No. What did I do wrong? Let's see. Well, I can tell you a little bit about myself. In the meantime, it's a good starting point. I'm from the Danish Health Data Authority. I'm a Master of Law, and I have been a leader of the legal department for the past 3 years. So, and I've been sent to the negotiations of the EHDS as an expert for Denmark. So, well, let's see if the presentation will be up. I can tell you something about what we're trying to do in Denmark for the implementation. We've been a little bit slow or starting out with analyzing how the EHDS would be implemented in Denmark, because we have a health reform which will reform all the health sector in general, both regarding digitalization and healthcare in general. So we're trying to turn around. It's right there. It's right there. It starts with a little bit of paper plane, a little bit down. Yeah, that's it. No, but you'll get it, I think. There we go. It's a small entity with 320 employees. Will be a little bit more right now. And in a year and a half, will be 680 people, because we're centralizing a lot of data going across country, both in the primary and the secondary use. So, Danish Health Data Authority is a lot of different things. We collect data about the Danish people from birth to death, and all the things in between when you're in contact with hospitals, GPs, and other things, municipalities, health services, everything. So we have this framework in Denmark as of now. The GDPR, the Danish Data Protection Act, and the Danish Health Act, and a lot of other Danish acts on health or on medical devices or on medical or medicines. So we have this framework right now. It does not require consent on the secondary use from the persons involved when it's about data. If it's about your biological material or it's about your genetic data, it does require consent. And you can opt out of those two forms of research in Denmark. So we have another kind of opt-out than that is described in the EHDS. It may be processed without consent. Significant importance to society. It's the same frame as an EHDS, and it has to be. It's necessary. It has to be necessary for carrying out the studies, and it is, of course, provided that a controller or authority says yes. The golden thing about data in Denmark is that it's really derived and centralized about your CPR, your social security number. So we can always track people. We can always see regarding health, regarding your work, regarding your school and your grades, everything. It doesn't live in the Health Data Authority all data, but all data about your health lives there. And when I say all data, that's it's a truth with modifications, because we only get some data. We do not have medical journals. We have your diagnosis from the hospital, not from the GPs as of now, but we're getting it in a year or two. So Health data is stored by key actors as of now: municipalities, National Genome Center, hospitals, Statens Serum Institute, Institute of Serums, Bio and Genome Bank in Denmark, Clinical Quality Program, Statistics Denmark, Danish Health Data Authority, and biobanks. So we have a lot of data spread out over a lot of different actors, but it's still health data. It's not all of the other categories as they're given in the EHDS, which also is a challenge. I'll get back to that. We have a secure research platform is also the one things that are described in the EHDS, but it's not the same kind. And we do not have hubs and spokes as they're described. It doesn't say hubs and spokes in the EHDS, but we don't have, they're not interconnected. We have a platform. Statistic Denmark has a platform. Others may have platforms to treat data, but they do not interconnect as such. And you cannot, you can transport data into, and we cannot, from our platform, you can only get access to pseudonymized data, not personalized data. You can come with your own data set, put it in, and we will just pseudonymize it for you and put it into your data set. The challenges, the costs. Even though we're really digitalized in the Danish health system, it's a big ferry, and we need to turn it just a little bit to make it work for the EHDS, or a little bit and a lot. It's a lot about standards. Even though we have a lot of secondary data, it's not necessarily registered in the same way when we start registering, when we start getting data in. And our job as a Danish, as the authority, is to make the standards so the data will be the same. One of the challenges also of the EHDS for secondary use is, in our point of view, that the way we register data also derives from the way our healthcare system is. And if you don't know the background for the data, how the health system is provided, the data might seem the same when you're a researcher, but it's not. And that's a big problem, or it's something you need to take into consideration when you're making your research project. That some might be of a different kind. In Denmark, we are health insured. Every Dane is health insured. It's free to go to the GPs. They have a very specific interaction with each other. So one of the, it's a hearsay, I can bring an example, but it's a hearsay example. I've heard of a study, an American study where they studied the how good you were in a country to remove mandibles. They concluded that in Denmark it was very dangerous to get your mandibles removed because it had many very, very bad endings. But they didn't look at the background for the data. In Denmark, you get your mandibles removed at a private practitioner if it's an easy operation. If it's a hard and difficult operation, you get it done at the hospital. But our registries had only the data from the hospitals. So that's an example of how wrong you can interpret data, even though it's the same. Well, data quality. We talk a lot about it also in the EHDS or in the negotiations, because not all data is good data. Some are better than others. Some are more relevant to use. Some are not relevant to use. We have the new rights for citizens, the opt-out, and the right to see who has been using your personal data for their research project. We do not have that kind of insight in Denmark today. It's a black box, relatively speaking. You have no right to see into the data that has been used for a research project, only on health data. Time. We have a metadata catalog. In Denmark, we have started a little bit on doing all of these things even before the talks about the EHDS was started. I'll say a little bit about that later. Platforms, what platforms do we use? What are the technical issues? The extent of data is also a thought worth having, because we know a lot of the data, it's health data, but there's also data that are determinants of health. That is a category we do not know what is and contains. It could be data about how much you pollute anything. It could be environmental data in its origin, but if it has an impact on health, it could be affected by the EHDS. And the amount of data holders. In Denmark, we have a huge amount. Even though I showed you a couple of bubbles before, we think that we haven't even made the analysis of how many entities that are not micro enterprises that will have health data. So that's a concern. So numbers increase. Purposes also are somewhat different to what we know today. We have statistics and research, but there is innovation and underpinning AI developments, and we don't really know what that is. Of course, we think that research also entails innovation, and it's in the same category or undercategory, but we don't know how to distinguish these two yet. Then there is challenges in our current setup. They're technical, they're organizational, and also a very important one is the personal resources, or resources of personnel, and the data governance that needs to change a whole lot regarding what we do today, because we have different entities that has data that approves access to data. We have the regions that approves access to patient journals. We have us who we give access to our registries. All the bubbles I showed you before, they give those approvals. So you have to go a lot of places right now to get data, to even have a project. Then there is the IP rights and trade secrets. I'm really hesitant to say that, because it's not an assessment we make today, because we don't have data that has those kind of secrets in them. Not in the Health Data Authority, we don't. I think maybe the regions does when they have research, but we don't. So how do we get the qualified staff to even notice if the health data holder has said the right thing about their IP rights or their trade secrets? What if the HDAP makes data available and then the IP rights are leaked in some way? Or what do we do in this collaboration? And how is the collaboration between the data authority, maybe the authority that normally judges IP rights and trade secrets? How does that even entail? The new rights to direct access to information on the usage of individual health data for secondary use, I talked about this before, and the opt-out. The opt-out is different in the EHDS than it is in Danish health law as it is of now. And we haven't really ended on what we're going to do in Denmark, so we're still talking about it. We have the IT systems that we need to redirect to fit some of the standards that the EHDS will propose on the later terms. Then there is ensuring the trust, and I'm really sorry that it was on the last time, because it really should be the first. In Denmark, we have a high level of trust, and that trust could be diminished if we don't make it. I lost the word. No, but if we don't really succeed in telling people about what their rights are, what different rights they have, how much we protect their data, that it's safe in the hubs that we use, that the cybersecurity is okay, that even though it's interconnected, it doesn't matter because we do it safely. The researchers would only have access to depersonalized data. All those things, we need to do that to ensure the trust, because in Denmark, we trust the governmental researchers. We trust them, but the private researchers, we think they have they make money out of the data. We think that they're easier to leak data, and they don't really mine data in the same way as the government does. So, and I know for other member states it's the other way around. So, potential solutions? Well, in the Danish landscape, we're changing not everything, but a lot. We have a health reform that will change all the way we even have a Danish health system as of now, in small parts and in big parts. And data, let's say the health reform has 40 tracks. Data is one of them, so it's a big reform for Denmark. We have already started with the vision. We started it a couple of years ago, making a metadata catalog that is much more detailed than the one that is represented in the EHDS. We are trying to make a one-stop shop, as described in the EHDS, but we already started now to try and do it. We're changing the governance. When I said we're going to be 600 people in just a minute, that's because the Danish Health Data Authority will stop existing in the next year and a half and will become the Digital Health Denmark instead, and will collect a lot of entities across Denmark regarding data. It's also a change of finance and distribution and all other things. We need to strengthen the data governance. We need to have legal clarity. Technological security measures needs to be done, and education and awareness is very important to keep the trust. We have to have a really close cross-border collaboration. Also, just around the GDPR. There's a different interpretation in different countries, and the EHDS expects us to treat all researchers' applications in the same way across Europe. So that's also a big thing. We need to monitor and audit a lot of things and have a lot of transparency and communications. That was my point of view, or our point of view for Denmark. Do you have any questions? No? Well, then that's it.